ultrasound lovers, Christina here. In this video, I want to review some of the key echo findings in patients with hypertrophic cardiomyopathy. The goal of this video is not to teach you how to be a cardiologist. This is a very nuanced diagnosis that we're not going to be making at the bedside, but I do think it's important for us at the point of care to be able to recognize features of hypertrophic cardiomyopathy, especially in presentations like syncope, new heart failure, chest pain, so that you can identify high-risk patients that need further workup. Quick review, what is hypertrophic cardiomyopathy? Well, as defined by the American Heart Association, it's an unexplained left ventricular hypertrophy associated with non-dilated ventricular chambers in the absence of another cardiac or systemic disease that would be capable of producing the magnitude of hypertrophy seen. And why talk about this? Well, we saw this patient recently in the ED with no known cardiomyopathy diagnosis, and this was the bedside ultrasound. And when reviewing these images, I wasn't clear on the features of hypertrophic cardiomyopathy. Is this septum too thick? Does this patient have obstructive physiology? And so I looked into it, and to answer these questions, I'll quickly review some of the key echo findings in this condition. Some are simple and some are more advanced, and you can just choose what works for you from this video. We'll start with the left ventricular wall hypertrophy. So left ventricular wall hypertrophy is almost always asymmetric, with the septum being the thickest. This thickening can happen in different ways, as you see in this image, and the two most commonly seen are reverse curvature, which is seen in younger patients diagnosed with this condition, and sigmoid up here, which is seen in older patients. And that's kind of the pattern that you saw in the clip that was on the earlier slide. And here are some representative echo stills. Notice in this slide, this super thick septum here that I don't think any of us would miss. And then in this slide, you can see the sigmoid septum here. So how thick is too thick? Well, guidelines differ, but the generalized agreement is that left ventricular wall thickness in any myocardial segment greater than or equal to 15 millimeters is concerning for hypertrophic cardiomyopathy. 13 to 14 millimeters here is borderline and should prompt further workup in patients with a concerning history, and especially those who have a family history of the condition. As you see here, there's this gray area. Elite athletes can actually hypertrophy their left ventricular muscle, and up to 2% of the time represented here can range from 12 millimeters all the way up to 16 millimeters. Patients with hypertension can also hypertrophy their LV. Most only go up to about 13 millimeters, but a small portion of patients can also hypertrophy up to 16 millimeters. How can you tell if it's hypertension or hypertrophic cardiomyopathy? Well, it's complicated. A quick rule of thumb is something called the septal to posterior wall thickness ratio. In normotensive patients, a ratio greater than 1.3, and in hypertensive patients, a ratio greater than 1.5 is highly suspicious for hypertrophic cardiomyopathy. In simpler terms, if the septum is much thicker than the other walls, you should worry about hypertrophic cardiomyopathy. LV wall measurement is done in the parasternal long axis view, either in a still clip or an M mode. This measurement must be done at end diastole when the LV chamber is the biggest and the muscle is at its smallest, and this is to avoid overestimating the muscle thickness. And then to get the ratio, you'll measure the septal thickness, which is here, and the posterior wall thickness, which is here, and then find the ratio. Measuring in M mode makes identification of end diastole easier. Here you see the septum and the LV chamber, and then the posterior wall here. This is diastole right here, and this is systole here where the muscle is contracting. Measure here at end diastole, again to get the thinnest wall measurement. This image shows a measurement both of the septum and the posterior wall in end diastole, and then a measurement here in peak systole. The numbers are up here just to give you an idea of how the wall thickness can change between diastole and systole. Just a hint, this is a normal heart, which is why you see the septal thickness looks normal. Diastolic dysfunction is a key finding in these patients as well. Because of the LV wall hypertrophy, some myocardial fibrosis, and changes in the intracellular calcium handling, the LV has impaired filling. Diastolic dysfunction is a whole other talk, and luckily Irene Ma, one of our other fellows, has already made a great video that you can find on our website. For those of you that have already learned and need a refresher, here's a quick table to remind you. Obstructive physiology is what most people think about when they think of hypertrophic cardiomyopathy. Left ventricular outflow tract obstruction is present in up to 70% of patients with hypertrophic cardiomyopathy. Obstruction can be either resting or provocable and is defined as an LVOT gradient of 30 millimeters of mercury or more. How do you measure the LVOT gradient? So this is clearly a bit more advanced. If you're just learning echo, ignore this part, but if you're comfortable, keep listening because it's interesting. So first you need to get a good image of the LVOT, and this is done with either the apical 5-chamber view or the apical long axis view, also called the apical 3-chamber. I think most of us are pretty familiar with the apical 5. This is kind of the apical 4-chamber view, and you peek up into the outflow tract. It's obtained by placing the probe at the apex of the heart with the probe marker to the right in our ED screen marker on the left convention. And then to obtain the apical 3-chamber view, you'll start in your apical 4 or 5 and then rotate the probe approximately 120 degrees counterclockwise, so the probe marker ends up pointing to approximately 5 o'clock. And when you get this image, you'll see the left ventricle here, mitral valve, left atrium, and LVOT, which is our point of interest. After obtaining one of these images, place the continuous Doppler through the LVOT. So you'll be placing it through here, or in this case, through here. You'll then get an image similar to this, and this shows the velocity of blood through the LVOT over time, and we want to find the peak velocity, which you'll see just at the tip of this. The cardiology package on the machine can then calculate the peak gradient from this peak velocity. And if you don't have a cardiology package, the peak gradient can be estimated using the modified Bernoulli equation, which is peak gradient equals 4 times the peak LVOT velocity squared. Why do these patients get obstruction? It's from a combination of structural changes in the heart. The septal hypertrophy alone narrows the left ventricular outflow tract. And in addition to this, there's elongation of the mitral leaflets and anterior displacement of the mitral valve apparatus. These together lead to something called systolic anterior motion of the mitral valve. In clear language, this means that the anterior leaflet of the mitral valve moves toward the septum during systole when it should be closed, and this causes a dynamic obstruction. This clip demonstrates systolic anterior motion. It's a zoomed-in clip of a peristernal long axis view. Here's the LV, here's the septum, left ventricular outflow tract, mitral valves. And let's take a look through slow motion. So here is diastole, where the LV is filling. You can see the mitral valve is open normally. And then here we're coming towards systole, where the leaflets come together. Now see how the mitral leaflets are touching kind of in the middle rather than the tip, leaving this portion sort of hanging in the breeze. And then during systole, the blood goes quickly through that narrowed LVOT, and then likely due to venturi forces, this extra little bit of leaflet gets sucked back into that LVOT. And you can see here's that tip of the mitral valve leaflet, and you're completely obstructing this outflow tract when it should just be closed. And that's systolic anterior motion. This is a major determinant of the presence and severity of the dynamic left ventricular outflow tract obstruction in hypertrophic cardiomyopathy. So systolic anterior motion can be seen on the peristernal long axis view in a clip, but it's much more easily seen in M mode with the cursor placed through the valve. Here is the very thick septum here, extremely thick, the LV chamber, and then the mitral valve here. This pattern demonstrates normal mitral valve movement during diastole, and then during systole, which is this portion, the valve should just be still and not moving. In this image, we see the valve move during systole up and touch the septum, causing obstruction. This is the systolic anterior motion seen on M mode. If you see this, please don't send your patient home. So I know that was a lot of information, but here's a snapshot of just the key points. So you should suspect hypertrophic cardiomyopathy when you see an LV wall thickness greater than or equal to 15 millimeters. Further, if you see a septal to posterior wall thickness ratio greater than 1.3 in normotensive patients or greater than 1.5 in hypertensive patients, an LVOT gradient greater than or equal to 30 millimeters of mercury at rest or with provocation, and if you see systolic anterior motion. That's it for now. Check back on our website soon for new videos.